A very good morning, everyone. So today I'll be talking about the role of lymphangiogenesis as a new avenue for therapeutics in liver diseases. And this will be the outline of my talk, where I'll cover lymphatics in general. Then I'll talk about lymphangiogenesis as a therapy, taking evidences from other diseases. And then the potential therapeutic role of lymphangiogenesis in liver disease. And here I'll cover lymphatics in the liver, in the brain, and finally in the gut. So we all know that lymphatics are one-way drain pipes, and they consist of a network of vessels, collecting vessels, and the lymph nodes. And their major function is to absorb the extra fluid which has been extravasated from the blood capillaries to the interstitial spaces and then return back to the blood through the venous circulation. And the general functions include fluid balance, immune cell trafficking, fighting infection. And besides these general functions, every organ has some specific lymphatic role. And in recent years, the role of lymphatics has come up also in tissue growth and regeneration and waste clearance. And we know that intestinal lymphatics are importantly involved in the lipid transport system. If we look at the organization of these vessels, anatomically, these vessels can be categorized into lymphatic capillaries, which are lined by single-celled endothelial cells, the pre-collectors and the collectors, and both the pre-collectors and the collectors have a smooth vessel wall covering, which helps in the propulsion of the lymph. So lymph moves from the interstitial spaces to these pre-collectors and then finally to these collecting vessels. And if we talk of the lymph flow, three important dynamic parameters that govern lymph flow is the hydrostatic pressure, the oncotic pressure exerted by the proteins, and certainly the permeability of the vessels. So two important factors are permeability and the contractility, which allows the lymph to propel to the blood vessels. So two important components in the lymphatic vessels are lymphatic endothelial cells and the lymph nodes. So as I just discussed, that the initial lymphatics or the pre-collectors and the lymphatic collectors, they all are lined by lymphatic endothelial cells, and in all these regions, the lymphatic endothelial cells can be identified by distinct markers. And in my study, I'll be talking about LYVE1, podoplanin, PROX1, and VGFR3. And these lymphatic endothelial cells, they actually, besides lining the covering, they are not just passive covering cells, but they also modulate the entry of immune cells into these capillaries and drain them into lymph nodes. So they also have a immunogenic role in these vessels. And when we talk of lymph nodes, so this is the organ where the lymph from the lymph capillaries drain. And these nodes, we all know, are important mediators of the adaptive immunity. They act as barriers, filtration barriers, and they help to contain the pathogens locally in the organ so that it doesn't spread systemically. Now, the impaired lymphatic function is called as lymphedema. So this lymphedema has several attributes. There's a regression or hypoplasia of these capillaries. There is a lack of lymphatic drainage functions. Then there is a dilation of these collecting vessels. There's a valve dysfunction. There's also an abnormal coverage of these smooth muscle cells, which lead to lack of or the dysfunction in the contractility of these vessels. And all these actually change the fluid dynamics. There's decrease in oncotic pressure, there's increase in hydrostatic pressure, capillary hydrostatic pressure, and there's increase in capillary permeability. So the result is lymphedema or lymphstasis, which actually leads to compensatory lymphangiogenesis. So if we look closely at lymphangiogenesis, so there are two factors, VGFC and VGFT, which are pro-lymphangiogenic factors. These actually strongly bind to a receptor, which is a receptor tyrosine kinase, VGFR3, also called as FLT4, and induce lymphangiogenesis. These factors also weakly bind to VGFR1 and 2, which we know are important for inducing angiogenesis by factors known as VGFA and VGFB. But here, what important point I want to mention is that there is a recombinant form of VGFC, which is mutated at 156 position, which specifically binds to VGFR3 and stimulates only lymphangiogenesis and not angiogenesis. And in most of the therapeutic studies, this recombinant has been used. Now, if we look closely at the relationship between angiogenesis and lymphangiogenesis, so in homeostasis, there is a balance. We have a normal drainage of tissue fluid because angiogenesis is very intricately balanced with the lymphatic vessel growth. Then, in a wound healing response, there's an increase in angiogenesis, also accompanied by increase in lymphangiogenesis. Again, this is a balanced situation. What happens when this balance is disturbed? So this is an imbalanced situation. You have more angiogenesis, but which is not associated by lymphangiogenesis. So this is this imbalance which leads to regression of lymphatic vessels, a defective lymph flow, thus leading to all complications. And this is here we propose therapeutic lymphangiogenesis. Now, lymphangiogenesis as a therapy from other diseases. Usually I will talk about VGFC-induced therapies, and there are a number of studies. Due to paucity of time, I will not take up all, but I've just taken up few landmark studies, and the major message is that VGFC increases the functional lymphatic vessel proliferation, reduces inflammation, increases drainage, and improves many attributes of the immune system. So the paper first, which came in 2010, it actually described the therapeutic role of lymphangiogenesis in skin inflammation. So in this study, they made this model of psoriasis, skin inflammation, by using a sustained activation of VGFA. So VGFA transgenic mice was used as a model of psoriasis, and in this you see that there was a lot of inflammation or increased edema. But when they used a VGFA and a C double transgenic mice, they showed that this inflammation or edema was reduced both histologically and clinically. And you can see when they looked at what was happening in VGFA-C double transgenic mice, so there was no change or there was a decrease in the blood vessel numbers, but there was an increase in the lymphatic vessels, which showed that increase in lymph vessels might be therapeutic. And this was also validated in this study when they used this recombinant mutant VGFC protein in this psoriasis model, and they showed that the inflammation or the edema reduced. Then just recently another experimental study showed how a targeted therapy using VGFC. So in this they used VGFC and they made a fusion protein. VGFC was fused to F8 antibody. F8 antibody is nothing but just an antibody which binds to the fibronectin portion of an inflamed tissue. So this is targeted towards the inflamed tissue, and in another model of psoriasis which was induced by a equimod, and in this they used this therapy and they showed again that this targeted therapy was reducing the edema, it was increasing lymph proliferation or the lymphatic vessel density, and it was also improving the lymphatic clearance, which was shown by in vivo imaging. So this study clearly showed that how a targeted delivery represent a new approach for treatment of chronic inflammatory skin diseases. Then in several studies of inflammatory bowel disease, it has been shown that in this disease there's an increase in the number of lymphatic vessels in the colon. So this has been shown, and this increase in the numbers is also associated with increase in the diameter. So they are dilated lymphatic vessels. There's an increase in VGFC. So there is a compensatory lymphangiogenesis. But again in this disease, these authors have done a systemic delivery of VGFC using a adenoviral vector method, where they showed that this adenoviral vector increases further VGFC, which is characterized by LYV1 staining. And when they saw the animals histologically and also clinically, it showed that it improved colitis, and the antibody that is anti-VEGFR3, which reduced lymphangiogenesis, was actually harmful, and it increased the disease both endoscopically and histologically. Again, the study showed the potential use of VEGF-C as a novel therapeutic approach for IBDs. Then in heart lymphangiogenesis, this has been very elegantly shown again in many studies, that after myocardial infarction, at 4 and 12 weeks, there is an increase in small collecting lymphatic vessels. And in this study, actually, they have distinguished the small lymphatics with pre-collectors. So there is an increase in the small lymphatics, but a decrease in the pre-collectors, that is podoplanin positive, a transient decrease at 4 weeks post myocardial infarction. So in this study again, what they gave was 2 doses of VEGF-C at a low dose and a high dose. This VEGF-C was encapsulated in albumin alginate microparticles, and you see here that in both low dose and high dose, there is an increase in the lymphatic vessel growth. In the low dose, we see more of the small lymphatics coming up, and in the high dose, we have more of the LYV1 positive collecting vessels and also decreased diameter. So now when this low dose and high dose animals were compared, the study showed that this actually improves the fluid imbalance post myocardial infarction. In the high dose, this was improved within 3 weeks, both in the infarct region and in the other non-infarct region. And in the low dose, it was improved within 8 weeks. So improvement was there in both doses. This also reduced cardiac fibrosis in the low dose within 3 weeks, in the high dose within 3 weeks, and the low dose within 8 weeks. Now, in another recent study, they showed that VEGF-C driven cardiac lymphangiogenesis is actually clearing immune cells from the heart. So you can see here all VEGF-C treated hearts, they showed low numbers of leukocytes, myeloid cells, neutrophils coming down as compared to the vehicle, which again proved that lymphangiogenesis is actually benefiting the immune response. Now, these were all preclinical studies. If we look at the clinical trials, so somehow the preclinical studies in these diseases have not translated into clinical trials. But yes, in lymphedema, where the lymphedema we know is a common complication in breast cancer patients, lymphactin, which is a VEGF-C adenoviral therapy, has been shown beneficial for patients, and this study has followed the patient for both 24 months and also the 12 months. And in, the study has clearly shown that the dose of VEGF-C is well tolerated and improves the quality and also reduces edema. So in this study, they have taken VEGF-C plus the lymph node treatment. These are some of the other clinical trials for lymphangiogenesis, but again in lymphedema patients. Here mostly people have used cell therapy, where they have shown adipose-derived stem cell and bone marrow cells also induce lymphangiogenesis. I'm not going into details. Now, if we talk of lymphangiogenesis in liver diseases, so lymphatic vessels, it was shown in 1998 in a case of idiopathic portal hypertension. You see here, the number of lymphatic vessels are very much increased in patients with IPH as compared to the controls, and this was not accompanied by increase in the portal vein. Now, lymphatic vasculature after this study has been shown to increase in all the liver diseases irrespective of the etiology. And most importantly, this has also been shown to increase stage-wise. So that means lymphangiogenesis is not merely a cause, but also increases with the progression of the disease. So in a study where experimental model of high-fat, high-cholesterol diet or NASH model was used, the study showed that also not the number of podoplanin positive or the lymphatic vessels are increased, but actually some of the functional markers, expression of some of the functional markers are decreased in NASH. So this study also clearly showed that if we give recombinant VEGF-C, it improves the drainage of the lymphatic system. And this was seen by seeing the drainage in the portal lymph nodes, and this was not observed when they actually saw the inguinal lymph nodes or in the plasma. So again, VGFC is improving lymphatic vessel proliferation in the liver and the lymphatic drainage. So in this study, they also showed another important point, that if we just give oxidized LDL to these animals, in control animals, then also the lymphatic drainage is decreased, just similar to what we have seen in the high fat, high cholesterol diet. And mechanistically, this oxidized LDL actually changes the lymphatic endothelial cell permeability by altering the expression of VE cadherin. So this one study was the first one to identify liver lymphatic system as a target to modulate hepatic inflammation in the NASH system. Now, coming to brain lymphatics, so actually this was a new system which was identified in the brain, the lymphatic system. So in this study they showed that not only the meningeal lymphatics but also the glymphatics, which are formed by the microglial cells, all this is reduced in a model of hepatic encephalopathy, which is a bile duct ligation model. And this glymphatic system reduction is actually due to a reduced expression of a protein which is aquaporin. And this glymphatic system defect is associated with behavioral defects in these hepatic encephalopathic rats. This decrease in drainage leads to increased microglial activation, increased neuroinflammation, and reduced motor function. Now, just 2 years after this study, it was Iwakiri who showed that if we give recombinant VGFC in the meninges directly through adenoviral method, it improves improves meningeal lymphangiogenesis and the lymphatic drainage. And the improvement in lymphatic drainage decreased microglial activation, neuroinflammation, and also ameliorated the motor dysfunction in the BDL rats. Then coming to the gut. So this study was long back, which showed the importance of gut lymphatics in cirrhosis. In experimental cirrhosis, they showed that the mesenteric lymphatic endothelial cells have high expression of eNOS and high nitric oxide in cirrhosis as compared to the controls. And this was associated with a decreased lymphatic vessel growth and drainage in these cirrhotic rats. So this study was actually the one important study which showed that liver lymphatics may play a major role in pre-ascitic condition, but gut lymphatics are crucial in the cirrhotic complications. So if we look at gut lymphatics more closely, so these are lacteals, important for lipid transport, and they are followed by the collecting vessels. These are all lined by lymphatic endothelial cells, crucial for maintaining immunity. And these gut lymphatic channels actually are connected directly to the blood, and they bypass the liver. And both the gut and the liver lymphatic vessels, they contribute maximum amount of abdominal lymph into the systemic blood. So if we look at gut lymphatics and ascites, it is nothing but gut lymphedema. So this abdominal ascites, we know there is a 30-fold increase in production of lymph. Increased production of lymph means reduced lymphatic drainage. And this reduced lymphatic drainage is all due to dysfunctional gut system. We have increased diameter, altered contractile activity or flow, lymph leakage, lymph stasis, which contributes to ascites. So, besides the ascites, gut lymphatics have also shown to be associated with increased bacterial translocation and sepsis. So in this study, what they have done is they have targeted ablation of the gut lymphatics and shown that the animals died within 60 hours, and the major mechanism they showed that there was a loss of clearing of pathogens in the draining mesenteric lymph nodes. And we all know how important mesenteric lymph nodes are for bacterial translocation even in cirrhosis patients. Now, in our study, we first asked the question, what is the clinical relevance of gut lymphatic vessels in patients with cirrhosis? So, we designed a study, although first initially we thought of taking NASH patients, but then we were finding dilated gut lymphatics in all patients irrespective of etiology. So we divided the group as compensated, decompensated. So we took these duodenal biopsies and then studied the gene expression of lymphatic vessels and the lymphatic vessel in these biopsies. I'm not taking up the whole study, but just to show that what we studied was podoplanin positive lymphatic vessels, And we actually marked these two parameters, the intensity and density of these lymphatic vessels in these biopsies. And it was clearly seen that as compared to the controls and the compensated cirrhosis, the decompensated cirrhosis, irrespective of etiology, have dilated, increased LVs. That means they have a high podoplanin score, and this was also higher in patients with the complications. So again, not going into details, but yes, higher podoplanin score patients also showed higher mortality, and on regression analysis, this podoplanin score emerged as a significant predictor of mortality of 90 days in both univariate and multivariate analysis. Then next, we asked the question, can we enhance the gut lymphatic drainage, reduce ascites in the advanced liver disease by using VGFC? So we know major limitation of VGFC is its half-life, its side effects. So here our approach was to use a nano formulation of VGFC. And again, I'm not going into details, but we made this VGFC encapsulated in the nanolipid carriers. This work was done in collaboration with Naipur Guwahati people, and this lipid nanocarriers were extensively characterized both biophysically and also in the in vitro study. And then this was followed by an in vivo study where we used 4 models of cirrhosis with portal hypertension, without non-cirrhotic portal hypertension. We also used a model where we have given VGFC or VGFR3 inhibitors, that is the SAR, and then we analyzed all the endpoints. Again, I'm not going into the details. This study is well published, work done by my student Pinky. So this therapy we showed increased the gut lymphatic vessels. It improved the drainage. It led to attenuation in portal hypertension. It led to attenuation in portal hypertension in both cirrhotic and non-cirrhotic models. It increased the activation of immune cells in the lymph nodes. It limited bacterial translocation, and when we inhibited lymphangiogenesis, it led to the reduction of this drainage and increased bacterial load in the nodes. So mechanistically, we found the higher expression of VCAM in these models, which was affecting the lymph vessel permeability. So coming to the last slide, we know that lymphatic system is an untapped potential therapeutic target. During injury, there is a compensatory, certainly increase in lymphangiogenesis, but this is insufficient because the vessels are dilated and there is a decreased expression of some of the lymphatic specific functional markers which disrupt the normal functioning of these vessels. And when I say increased compensatory lymphangiogenesis, I'm not talking about the liver, but the lymphatic system as a whole. Gut lymphangiopathy certainly worsens cirrhosis. It leads to or is important progression of the complications in cirrhosis. And if we modulate lymphatic vessel growth by giving VGFC or activating the VGFC-VGFR pathway, it certainly holds immense potential to manage ascites and other complications. So in the gut-liver axis, which we just heard from Dr. Anupam, what our contribution is to add another tier of knowledge of saying that gut dysfunctional lymphatic system leading to impaired fluid drainage, weakened gut immune surveillance, increased bacterial load actually can be resolved by a lymphatic vessel targeted using VGFC or lymphangiogenesis. And our next steps are what we are doing currently with industry is scaling up the recombinant VGFC production, scaling up of the lipid nanocarriers so that we can take this therapy, take our findings into clinical translation. So thank you all, and my acknowledgements are due to everybody who has helped in the study in one way or the other. And most importantly, thank you to our funding agencies, DST and SARB, who has funded, given us 2 projects on this topic. Thank you.